Welcome to Pediatric Case Review. I am Dr. Abdelaziz Yousef, and today we will explore the differential diagnosis of renal masses in children. This comprehensive lecture will provide you with essential knowledge for identifying, evaluating, and managing various renal conditions in pediatric patients. Understanding these conditions is crucial for pediatric residents as they form a significant portion of abdominal masses encountered in clinical practice. Throughout this presentation, we will use case-based questions to enhance your clinical reasoning skills. This lecture is designed to provide pediatric residents with a comprehensive understanding of renal masses in children. We will cover the most common causes including Wilms tumor, neuroblastoma, renal cysts, hydronephrosis, and multicystic dysplastic kidney. Our systematic approach will help you develop clinical reasoning skills for accurate diagnosis. We will explore appropriate imaging techniques and their interpretation, followed by evidence-based management guidelines. Each case-based question will simulate real clinical scenarios to enhance your diagnostic and therapeutic decision-making abilities. A 4-year-old boy presents with a painless abdominal mass discovered during routine examination. Physical exam reveals a firm, non-tender mass in the right flank. What is the most likely diagnosis? Option A, neuroblastoma. Option B, Wilms tumor. Option C, renal cyst. Option D, lymphoma. Consider the age of presentation, the nature of the mass, and the most common renal tumor in this age group. The painless nature of the mass and the age are important clinical clues to guide your diagnosis. The correct answer is B, Wilms tumor. Wilms tumor typically presents as a painless abdominal mass in children aged 3 to 4 years, which perfectly matches our case. It is the most common renal tumor in children. Neuroblastoma usually presents with a painful mass and often crosses the midline. Renal cysts are typically fluid-filled and not solid masses. Primary renal lymphoma is extremely rare in children. The painless nature of the mass, the age of presentation, and the location in the flank are all classic features of Wilms tumor. Wilms tumor originates from embryonal renal tissue and is the most common renal malignancy in children. It typically presents as a unilateral mass, with only 5 to 10% of cases being bilateral. On imaging, it appears as a well-circumscribed mass with the characteristic claw sign, demonstrating that it arises from the kidney. Important associated syndromes include WAGR syndrome and Beckwith-Weidman syndrome. The staging system ranges from stage 1, affecting only the kidney, to stage 5, affecting both kidneys. Management involves a multimodal approach with surgery, chemotherapy, and radiation therapy tailored to the stage and histology of the tumor. A 3-year-old girl has an abdominal ultrasound showing a well-defined renal mass with internal calcifications. Which of these features is least consistent with Wilms tumor? Option A, well-defined margins. Option B, extensive calcification. Option C, confined to kidney. Option D, heterogeneous appearance. Consider the typical radiologic characteristics of Wilms tumor and how they differ from other pediatric abdominal masses, particularly neuroblastoma. The presence and pattern of calcifications can be a key distinguishing feature between these tumors. The correct answer is B, extensive calcification. Wilms tumor shows calcification in only about 10% of cases, whereas neuroblastoma demonstrates calcification in 80 to 90% of cases. This difference in calcification pattern is a key radiologic distinguishing feature between these two common pediatric abdominal tumors. Well-defined margins, confinement to the kidney, and heterogeneous appearance are all typical features of Wilms tumor. The claw sign on imaging demonstrates that the mass arises from the kidney and is well circumscribed. Recognizing these radiologic differences is crucial for accurate diagnosis and appropriate management planning. This comparative table highlights key imaging features that differentiate common pediatric renal masses. Wilms tumor typically shows well-defined margins with the characteristic claw sign, minimal calcification in about 10% of cases, and rarely crosses the midline. Neuroblastoma, in contrast, demonstrates extensive calcification in 80 to 90% of cases, poorly defined margins, commonly crosses the midline, and in cases but does not invade vascular structures. Renal cysts and multicystic dysplastic kidney appear as well-defined fluid-filled structures without calcification. Ultrasound is the best initial imaging modality for all these conditions, with CT or MRI used for further characterization and staging. Pattern recognition of these features is essential for accurate diagnosis. A newborn has prenatal ultrasound showing renal pelvis dilatation. Postnatal ultrasound confirms moderate hydronephrosis. What is the most common cause of congenital hydronephrosis? Option A, posterior urethral valves. Option B, ureteropelvic junction obstruction. Option C, vesicoureteral reflux. Option D, ureterocele. Consider the epidemiology of congenital urinary tract anomalies and the most frequent etiology of prenatal hydronephrosis. The location and nature of the obstruction are important factors in determining the underlying cause. The correct answer is B, ureteropelvic junction obstruction. UPJ obstruction is the most common cause of congenital hydronephrosis, accounting for approximately 50% of cases. It results from a functional or anatomical blockage at the junction between the renal pelvis and ureter. Antenatal hydronephrosis diagnosed during pregnancy is usually mild, while postnatal hydronephrosis may indicate significant obstruction. Other common causes include vesicoureteral reflux, 20%, posterior urethral valves, 10%, seen only in males, and ureteric duplication. Posterior urethral valves, while important, are less common overall and occur exclusively in males. The approach to evaluation depends on the severity and clinical presentation, with follow-up imaging tailored to the suspected etiology. The management of hydronephrosis follows a systematic approach based on severity, grading using the Society for Fetal Urology or Urinary Tract Dilation classification systems. Mild hydronephrosis, grades 1 to 2, typically requires conservative management with follow-up ultrasound in 3 to 6 months. Moderate hydronephrosis, grade 3, may warrant voiding cystourethrogram if high-risk features are present, with follow-up in 1 to 3 months. Severe hydronephrosis, grade 4, requires prompt evaluation, often including an MAG3 scan to assess renal function and drainage. The management algorithm progresses from initial ultrasound grading to appropriate further investigations, culminating in treatment decisions between medical management, antibiotic prophylaxis, monitoring, and surgical intervention for worsening obstruction, decreasing function, recurrent infections, or symptomatic presentation. A 6-month-old infant has ultrasound showing multiple non-communicating cysts replacing normal renal parenchyma in the right kidney. The left kidney appears normal but enlarged. What is the most appropriate management? Option A, immediate nephrectomy. Option B, conservative management with follow-up imaging. Option C, antibiotic prophylaxis only. Option D, percutaneous drainage of cysts. Consider the natural history of multicystic dysplastic kidney and the compensatory hypertrophy of the contralateral kidney. The typical clinical course and current management guidelines for MCDK should guide your answer. The correct answer is B, conservative management with follow-up imaging. Multicystic dysplastic kidney typically follows a benign course with spontaneous regression over time. Complete involution occurs in up to 60% of cases by 10 years of age. The contralateral kidney undergoes compensatory hypertrophy, as demonstrated in our case, where the left kidney appears enlarged but normal. Current management guidelines recommend serial ultrasound examinations at 3 to 6 months initially, then annually until regression is complete or the child reaches school age. Immediate nephrectomy is rarely indicated and reserved for complications such as hypertension, infection, or malignant transformation. Antibiotic prophylaxis is not routinely needed, and percutaneous drainage is ineffective as the cysts are non-communicating. Multicystic dysplastic kidney results from abnormal interaction between the ureteric bud and metanephric mesenchyme during fetal development. The diagnostic criteria include multiple non-communicating cysts, no identifiable renal pelvis, absent or atretic ureter, and dysplastic parenchyma. It's crucial to differentiate MCDK from severe hydronephrosis, which shows communicating cysts, and polycystic kidney disease, which is typically bilateral and inherited. Associated contralateral urinary tract anomalies occur in 20 to 40% of cases, including vesicoureteral reflux and ureteropelvic junction obstruction. Long-term follow-up includes annual blood pressure monitoring, periodic renal function assessment, and ultrasound until complete involution. The prognosis is excellent with conservative management, and the risk of malignancy is extremely low, less than 1%. A 10-year-old child presents with flank pain. Ultrasound shows multiple bilateral renal cysts. Family history is significant for similar findings in the father. What is the most likely diagnosis? Option A, simple renal cysts. Option B, autosomal dominant polycystic kidney disease. Option C, autosomal recessive polycystic kidney disease. Option D, von Hippel-Lindau disease. Consider the age of presentation, the pattern of inheritance suggested by the family history, and the typical clinical features of each condition. The bilateral nature of the cysts and the positive family history are important clues to guide your diagnosis. The correct answer is B, autosomal dominant polycystic kidney disease. ADPKD typically presents in adulthood but can manifest in childhood with bilateral renal cysts. The family history with an affected father strongly suggests autosomal dominant inheritance with a 50% transmission risk. In contrast, autosomal recessive polycystic kidney disease typically presents in infancy with severe renal involvement and requires both parents to be carriers. Simple renal cysts are usually unilateral and single, not multiple and bilateral. Von Hippel-Lindau disease is associated with other tumors, including hemangioblastomas and pheochromocytomas. ADPKD is caused by mutations in PKD1 or PKD2 genes and can be associated with extrarenal manifestations including hepatic cysts, intracranial aneurysms, and cardiac valve abnormalities. This comparative chart outlines the key features of pediatric renal cystic diseases. Simple cysts can occur at any age, are typically unilateral and sporadic, with normal renal function managed by observation. Autosomal dominant polycystic kidney disease usually presents in adulthood with bilateral involvement, autosomal dominant inheritance, and progressive decline in renal function requiring blood pressure control and monitoring. Autosomal recessive polycystic kidney disease presents in infancy with bilateral involvement, autosomal recessive inheritance, severely affected renal function, and requires a multidisciplinary supportive approach. Multicystic dysplastic kidney is present at birth, unilateral, sporadic, non-functional, and managed conservatively with serial ultrasounds. Genetic considerations include PKD1 and PKD2 genes for ADPKD, PKHD1 for ERPKD, with genetic testing available for confirmation and family screening. A 2-year-old presents with irritability, weight loss, and abdominal distension. Examination reveals a firm, irregular, and painful abdominal mass crossing the midline. Laboratory studies show elevated urinary catecholamines. What is the most likely diagnosis? Option A, Wilms tumor. Option B, neuroblastoma. Option C, rhabdomyosarcoma. Option D, hepatoblastoma. Consider the age of presentation, the nature of the mass, painful versus painless, the location, crossing midline, and the laboratory findings. The elevated urinary catecholamines are a key biochemical marker that should guide your diagnosis. The correct answer is B, neuroblastoma. Neuroblastoma arises from neural crest tissue in the adrenal medulla and sympathetic chain, which explains the elevated urinary catecholamines, VMA and HVA. It typically presents in children under 2 years of age with irritability, weight loss, and a painful abdominal mass. Key distinguishing features from Wilms tumor include the painful nature of the mass, crossing the midline, and extensive calcification on imaging. The elevated urinary catecholamine metabolites are highly specific for neuroblastoma, with 90% showing elevated VMA and 85% showing elevated HVA. Rhabdomyosarcoma originates from soft tissue and would not show elevated catecholamines, while hepatoblastoma arises from the liver and typically shows elevated alpha-fetoprotein, not catecholamines. This comprehensive comparison highlights the key differences between neuroblastoma and Wilms tumor. Neuroblastoma typically presents in children under 2 years, originates from adrenal or sympathetic chain tissue, and manifests with an irritable child, painful mass, and constitutional symptoms. Radiologically, it crosses the midline, shows 80 to 90% calcification, and is poorly marginated. It encases but does not invade vessels, with elevated urinary VMA and HVA in 90% of cases. Wilms tumor presents at 3 to 4 years, originates from embryonal renal tissue, and is usually asymptomatic with a painless mass discovered incidentally. It shows the characteristic claw sign, has only about 10% calcification, is well circumscribed, invades vessels, and has no specific markers. Neuroblastoma uses the INGR staging system and may show spontaneous regression in infants, while Wilms tumor uses a 5-stage system and is managed with nephrectomy followed by chemotherapy. A 5-year-old presents with hematuria and a palpable right flank mass. Initial ultrasound suggests a solid renal mass. What is the most appropriate next imaging study? Option A, plain abdominal radiograph. Option B, contrast-enhanced CT abdomen/pelvis. Option C, MRI abdomen without contrast. Option D, MIBG scan. Consider the clinical presentation, the initial ultrasound findings suggesting a solid mass, and the need for further characterization and staging. The choice of imaging modality should provide the most comprehensive information for diagnosis, local staging, and detection of metastases while minimizing radiation exposure in pediatric patients. The renal mass imaging protocol follows a systematic approach starting with ultrasound to characterize the mass as solid or cystic. 4 solid masses, Contrast-enhanced CT is the preferred next step for comprehensive staging, providing excellent visualization of the primary tumor, local extension, vascular invasion, and distant metastases. MRI is selected in cases where radiation exposure is a concern or when better soft tissue characterization is needed. Nuclear medicine studies include MIBG scan for neuroblastoma and MAG3 scan for assessing renal function and drainage in hydronephrosis. CT is generally faster and better for lung metastases and vascular detail, while MRI offers no radiation exposure and superior local staging. Preoperative considerations include avoiding biopsy or needle aspiration in suspected Wilms tumor due to tumor spillage risk, completing imaging before surgical intervention, and performing chest CT for lung metastases. MRI may be considered if inferior vena cava involvement is suspected on CT for better vascular characterization. A 7-year-old boy presents after falling from a bicycle with right flank pain and microscopic hematuria. Ultrasound shows a subcapsular fluid collection. What is the most likely diagnosis? Option A, Wilms tumor. Option B, renal abscess. Option C, renal hematoma. Option D, renal cyst. Consider the mechanism of injury, fall from bicycle, the presenting symptoms, flank pain, microscopic hematuria, and the ultrasound findings, subcapsular fluid collection. The acute nature of presentation following trauma is a key factor in determining the diagnosis. The location of the fluid collection and the absence of fever or other signs of infection are also important clinical clues. The correct answer is C, renal hematoma. The history of falling from a bicycle with subsequent flank pain and microscopic hematuria strongly suggests traumatic renal injury. The ultrasound finding of a subcapsular fluid collection in this context is characteristic of a renal hematoma, representing blood accumulation beneath the renal capsule. Wilms tumor would not have an acute traumatic presentation. Renal abscess would typically present with fever and elevated white blood cell count, and renal cyst would not cause hematuria. Most pediatric renal injuries, grades 1 to 3, are managed conservatively with bed rest, hydration, and close monitoring. The renal injury grading system ranges from grade 1, contusion, to grade 5, shattered kidney, with management based on the grade and clinical status. Follow-up recommendations include repeat imaging to ensure resolution and monitoring for complications such as hypertension or urinoma formation. A 3-year-old is diagnosed with stage 2 Wilms tumor after nephrectomy. What is the most appropriate next step in management? Option A, observation only. Option B, radiation therapy only. Option C, chemotherapy only. Option D, combined chemotherapy and radiation therapy. Consider the current treatment protocols for Wilms tumor based on staging. Stage 2 disease indicates that the tumor has extended beyond the kidney but has been completely resected. The National Wilms Tumor Study Group protocols provide specific guidelines for adjuvant therapy based on stage and histology. The age of the patient and the favorable histology typically seen in Wilms tumor should guide your treatment decision. The correct answer is C, chemotherapy only. According to current National Wilms Tumor Study Group protocols, Stage 2 favorable histology Wilms tumor after complete nephrectomy receives adjuvant chemotherapy only. The treatment approach for Wilms tumor is multimodal, involving surgery, chemotherapy, and radiation therapy based on stage and histology. Stage 2 disease does not require radiation therapy. Observation only is reserved for Stage 1 disease, with favorable histology in children under 2 years of age. Radiation therapy alone is not used as primary treatment. Combined chemotherapy and radiation therapy is typically reserved for Stage 3 and 4 disease. The standard chemotherapy regimen for Stage 2 includes vincristine and dactinomycin for 19 weeks, achieving excellent survival rates of approximately 95%. Long-term follow-up considerations include monitoring for late effects of therapy and recurrent surveillance. Treatment algorithms for pediatric renal masses vary by diagnosis and stage. For Wilms tumor, Stage 1 is treated with nephrectomy plus or minus chemotherapy based on age, with chemotherapy added for children over 2 years. Stage 2 requires nephrectomy followed by chemotherapy with vincristine and dactinomycin. Stage 3 needs nephrectomy, chemotherapy, and radiation therapy with a 3-drug regimen. Stage 4 requires intensive chemotherapy plus radiation therapy, sometimes with stem cell rescue. Neuroblastoma treatment is risk-based. Low-risk cases receive observation or surgery with minimal chemotherapy. Intermediate-risk cases get moderate chemotherapy with surgery when feasible, and high-risk cases require intensive multimodal therapy, including immunotherapy and retinoic acid. A 2-year-old with aniridia is found to have a renal mass on screening ultrasound. Which genetic syndrome is most likely present? Option A, Beckwith-Wiedemann syndrome. Option B, WAGR syndrome. Option C, Dennis-Drash syndrome. Option D, von Hippel-Lindau syndrome. Consider the association between aniridia, absence of the iris, and renal tumors. The specific combination of ocular abnormality and renal mass should point to a particular genetic syndrome. Remember the components of each syndrome and their characteristic features. The age of the patient and the specific findings are key to determining the correct diagnosis. The correct answer is B, WAGR syndrome. WAGR syndrome is characterized by Wilms tumor, aniridia, genitourinary anomalies, and mental retardation. The association between aniridia and Wilms tumor is highly specific for this syndrome. It is caused by a deletion of chromosome 11p13 region, which includes the WT1 and PX6 genes. This genetic deletion explains both the tumor predisposition and the ocular abnormalities. Children with WAGR syndrome require regular renal ultrasound screening every 3 months until at least 8 years of age due to the high risk of Wilms tumor development. Beckwith-Wiedemann syndrome presents with macroglossia and hemihypertrophy, Dennis-Drash syndrome with nephropathy and ambiguous genitalia, and von Hippel-Lindau syndrome with hemangioblastomas and pheochromocytoma. Recognition of these syndromes is crucial for implementing appropriate surveillance protocols for early tumor detection. A 5-year-old with known ureteropelvic junction obstruction presents with fever, flank pain, and vomiting. Laboratory studies show elevated white blood cell count and creatinine. What is the most likely complication? Option A, renal calculi. Option B, pyelonephritis. Option C, renal abscess. Option D, renal infarction. Consider the relationship between urinary tract obstruction and infection. The presence of fever, elevated white blood cell count, and flank pain in a child with known obstruction suggests an infectious process. The elevated creatinine indicates some degree of renal impairment. The acute nature of the presentation and the combination of symptoms and laboratory findings should guide your diagnosis. The correct answer is B, pyelonephritis. Urinary obstruction creates a favorable environment for infection by causing urinary stasis, which allows bacteria to multiply and ascend to the kidney. The combination of fever, flank pain, vomiting, elevated white blood cell count, and rising creatinine in a child with known ureteropelvic junction obstruction is classic for obstructive pyelonephritis. Renal calculi would not typically present with fever and elevated white blood cell count. Renal abscess is usually a later complication of untreated infection. Renal infarction has a different presentation, often with sudden severe pain, but without fever and white blood cell elevation. Acute management of infected hydronephrosis requires urgent drainage of the obstructed system, typically via percutaneous nephrostomy or ureteral stent, along with appropriate intravenous antibiotics. A 14-year-old presents with hypertension. Renal ultrasound shows a hyperechoic mass in the left kidney. MRI shows fat-containing lesions. What is the most likely diagnosis? Option A, Wilms tumor. Option B, renal cell carcinoma. Option C, angiomyolipoma. Option D, mesoblastic nephroma. Consider the age of presentation, the imaging characteristics, hyperechoic on ultrasound, fat-containing on MRI, and the association with hypertension. The specific finding of fat within the lesion is a key diagnostic feature that should guide your diagnosis. The adolescent age group and the benign nature of the condition should also be considered in your differential diagnosis. The correct answer is C, angiomyolipoma. Angiomyolipoma is a benign tumor composed of blood vessels, smooth muscle, and mature adipose tissue. The presence of fat on MRI is pathognomonic for this diagnosis. While most angiomyolipomas are sporadic, they are strongly associated with tuberous sclerosis complex. Hypertension can occur due to renal involvement or compression. Wilms tumor does not contain fat and typically occurs in younger children. Renal cell carcinoma is rare in adolescents and does not show fat content on imaging. Mesoblastic nephroma is an infantile tumor that also does not contain fat. Management of angiomyolipoma depends on size. Small lesions, less than 4 centimeters, are typically observed, while larger lesions or those with symptoms may require intervention due to the risk of hemorrhage. The risk of hemorrhage increases with tumor size, and indications for intervention include size greater than 4 centimeters, symptoms, or female patients of childbearing age due to hormonal influences on tumor growth. Thank you for joining this comprehensive lecture on the differential diagnosis of renal masses in children. We have explored a systematic approach to evaluating these conditions, recognizing key distinguishing features between Wilms tumor, neuroblastoma, and other renal masses based on clinical presentation and radiologic findings. We have discussed appropriate imaging selection and interpretation for accurate diagnosis, staging, and follow-up. The management of these conditions requires evidence-based approaches tailored to the specific diagnosis, staging, and risk stratification. This knowledge is essential for pediatric residents in their clinical practice. Remember to consider age, presentation patterns, and characteristic imaging features when approaching a child with a renal mass. Early recognition and appropriate management can significantly improve outcomes for these patients.